All right, let's get right into it and talk about nasogastric tube management. We're going to go way beyond just the textbook steps here. We'll break down all the critical details, from the anatomy to the safety checks, that really make the difference between just doing the procedure and mastering it for expert patient care.
Okay, so first things first, what are we actually looking at? At its heart, a nasogastric tube, or NG tube, is a pretty simple tool that follows a very specific path. You can see it right here. It goes from the nose, usually the left nostril because the anatomy is a bit of a smoother ride on that side, down the esophagus, and it lands right where it needs to be, in the stomach.
You know, it's easy to think of this as just a feeding tube, but it's so much more. This one simple device actually serves three totally distinct critical functions. Of course, it can provide nutrition, but it can also be used to perform what's called a gastric lavage, to clear out harmful stuff, say in a poisoning case. Or it can even be used for diagnostics, like helping to confirm a tracheoesophageal fistula.
But here's the thing, it's not a tool for every single situation. You've always got to weigh the pros and cons. You have your go signals, the indications, like a patient who can't swallow or has been poisoned. And then you have your absolute stop signals, your contraindications, like if a patient just had nasal surgery or has nasal polyps. That's a fundamental safety check you can never skip.
Now, let's get into the gear. Choosing the right tool for the job is really the first step to success. And believe me, this is not a one-size-fits-all kind of deal. The specific task is going to dictate the specific hardware you need. In this picture, it really shows you what I mean. For something basic like feeding or decompression, you might grab a simple single-lumen Levin tube. But if you're managing something really serious, like a major esophageal bleed, you're going to need something much more complex, like a 4-lumen Minnesota tube. The right choice is absolutely critical for the right outcome.
And it's not just about the type of tube, it's also about the size. We measure these on what's called the French scale, and basically, the bigger the patient, the bigger the tube. Getting the size right is so important for both comfort and safety. You could be using a tiny 5 French for an infant, all the way up to a 22 French for a large adult male.
So you've got all these sizes, right? But if there's one number you're going to see over and over again in practice, it's this one, 18. An 18 French tube is, by and large, the most common, the go-to size for adult males. Think of it as the industry standard, your starting point.
Okay, let's dive into the core procedure itself. This is where the rubber meets the road, and success here is all about being meticulous with your prep and having a clear, practice technique. Look, if you take away anything, remember these 3 pre-procedure checks. They are totally non-negotiable. You have to get the patient's position right, get the device properly prepped, and measure that insertion length perfectly before you even think about starting. This is how you prevent complications down the line. And each step has a super clear reason behind it. Positioning the patient in high fowlers, that uses gravity to your advantage. That 4 degrees Celsius ice bath, it adds just enough stiffness to the tube so it doesn't coil up or, worse, go down the windpipe. And of course, the NEX method, measuring from the nose to the ear to the xiphoid process, that's how you guarantee you've marked the right insertion depth.
Now this is huge. During the insertion, you have to be watching the patient like a hawk. If you see any sign of respiratory distress, coughing, choking, gasping for air, the protocol is always the same. Stop and pull back immediately. You never ever force it against resistance. You wait for things to calm down completely before you even think about trying again.
Okay, the tube is in. You did the hard part, right? Well, not quite. Now comes the single most important question. Is it in the right place? Let's look at how we prove it.
I want you to think of this like a pyramid of proof. We're building a case here, layer by layer. At the very bottom, as a secondary check, you've got auscultation, listening for that whoosh sound. Moving up, you've got your bedside standard, the pH test. And at the very top, the absolute undeniable gold standard is an X-ray verification.
Now, an X-ray is the ultimate proof, no doubt about it, but you can't be wheeling a patient down for an X-ray every single time you need to check. So what's your best friend at the bedside? It's this pH test. You aspirate a little bit of the stomach contents, test it, and if that pH is less than 4, you know you're in the highly acidic environment of the stomach. Bingo.
Getting the tube in is really just the beginning. The real work is in the ongoing management or stewardship of that tube. This is absolutely key to preventing complications and keeping the patient safe over the long haul.
And a big part of that is managing what we call residual volume. This is a critical balancing act. Before every feeding, you have to check it. And the rule of thumb? It's super simple.
If the volume is over 100 milliliters, you hold the feeding and check again in 4 hours. But, and this is so important, you never ever discard that volume. It's full of essential electrolytes, and just tossing it can lead to a serious condition called metabolic alkalosis.
Look, while diarrhea might be the most common headache you'll deal with, aspiration pneumonia, that's the complication that's truly dangerous. And the prevention for it? It's actually incredibly simple, but you cannot forget it. The head of the bed must always be elevated to at least 30 degrees during a feeding. It's just simple gravity, preventing reflux and aspiration.
Okay, so what happens when we're dealing with an emergency, like a poisoning? The playbook changes a bit. It becomes a really strict sequential process. First, you inform the doctor. Second, you insert the tube. Third, you begin gastric lavage. And notice the key difference in positioning here, too. You move the patient onto their right side, which helps prevent aspiration in this specific scenario.
All right, let's do a quick fire round of the numbers you need to burn into your brain. Ready? 4 degrees Celsius for the ice bath to get the tube rigid. A pH of less than 4 to confirm placement. A 30-degree elevation for feeding safety, and a 100 milliliter threshold for holding a feed. Those are your critical metrics.
So when you boil this all down, what does it really come to? It's 2 things. 2 absolute pillars that hold up all of NGT safety. Rock-solid verification of the tube's placement and proper patient positioning. If you master those 2 things, you prevent the most serious complications and you deliver the highest standard of care.
And that's really something to think about, isn't it? Anyone can follow a protocol, but true mastery, the kind that defines excellent clinical practice, that comes from understanding the deep why behind every single step, and then applying that wisdom with precision and care. That's the difference, and that's the difference you make for every single patient.